Introduction to Radiology by our very own Prajwith sir. Sir, we can start the discussion now. So I'll hand over the stage to you.
Yeah, I hope today audio will be clear. I have full network also.
Yes, sir.
Yeah. So I'll just revise whatever we have taught quickly. We'll see what all we have seen the last class. So we know Marie Curie is the one who first discovered the theory of radioactivity was found by her and discovered radium and polonium. And Henry Becquerel is father of radioactivity, whereas Conrad Roentgen is father of radiology. John Wilde is father of medical ultrasound. Ian Donald is father of obstetric ultrasound. Charles Daughter is father of intervention radiology, and Godfrey Hounsfield is father of CT. Then we have the Bloch and Purcell who discovered the principle of NMR, and the magnetic resonance imaging was found by Paul Latimer and Peter Mansfield. Raymond Damadian introduced MRI in medical field. Okay, so and we know that in X-ray we use radio opaque and radiolucent, or radiodense and radiolucent. CT hyperdense and hypodense. MRI again hyper intense and hypo intense, and ultrasound we use hypo and hyper echoic. Okay, so and then we know that the electromagnetic radiation includes
Sir, your voice is not coming, sir.
I just was it clear in the first initial part?
Yes, it was clear, sir.
Okay, I don't know what happened suddenly. Okay, so then we saw the electromagnetic spectrum of radiations, including from the radio wave, microwave, infrared rays, visible and ultraviolet. Till here, everything were non-ionizing. Beyond this are all ionizing, along with other particulate matters like proton, neutron, helium nucleus, and electron. The one thing is, all of these are electromagnetic radiation. They will have common velocity. Okay, all of these will have common velocity. And one more thing is the wavelength differs and the frequency differs, and that's how they differ from each other. And the wavelength runs between 0.1 to 1 Armstrong. Okay, the wavelength spectrum is from 0.1 to 1 Armstrong, and energy is directly proportional to frequency. So gamma rays will have maximum velocity because it has maximum frequency. Okay, and we know that alpha particle, beta particle, gamma particles are originating from the nucleus, whereas the X-rays, gamma rays, X-ray was originating from outside the nucleus. Okay. Again, we had this non-ionizing radiation, which as I told again, ionizing radiation including gamma rays, X-rays, cosmic rays, and on the particulate matters. And also I have told about the penetration. The neutrons have the maximum penetration, alpha rays have the minimum penetration, and alpha rays are having maximum tissue damaging property. Okay, whenever there is a less penetration, it causes more tissue damage. Okay, so this all we have discussed the last class. Again, we have seen that thermography, the MRI, the ultrasound are the ones that are containing non-ionizing radiation that we use in radiology imaging. Whereas the ionizing radiation includes the X-rays, the mammography, the DSA, and fluoroscopy, the barium studies, the HSG, IVU, DEXA scan, and the CT scan. Whereas the nuclear medicine, whatever we use in nuclear medicine, that is the gamma camera and the nuclear scans are all based on the gamma rays, and also the PET scan is based on the gamma rays. Okay. Uh, and we have seen that IVU has two phase. There are multiple phases, but mainly we need to know the two phase. One is the nephrogenic phase. One is the excretory phase. Excretory phase can be again split into pylographic phase as phase and excretory phase proper. And we know that at 1 minute we'll get, if you take an image, we'll get the nephrographic phase, and later at 10 minutes we can get excretory phase. Okay, and also we can see the bladder, and we can see the excretory phase. We see Swiss cheese pattern in case of uh, autosomal dominant polycystic kidney disease, and also the spider leg appearance. Okay, this is an example of the same. We have the this is the Stagon calculi, which will sometimes mimic IVU. Okay, we should be very careful there. And this is not a IVU, this is a retrograde ureterography. Okay, this is a retrograde ureterography. You have to see the catheter. Whenever there is a catheter, we have to think it is a retrograde pyelogram. Okay, also very important that they will not ask you most of the time the diagnosis as such. They might ask you just the imaging, the finding, what diagnostic imaging is done. Okay, this is a micturition cystourethropy. It's an investigation of choice for the posterior urethral valve, as well as the mainly it is a investigation of choice for the vesico-ureteric reflex. As we see here, there is a vesico-ureteric reflex and a gross hydroureteronephrosis. And again, the urethra is divided into anterior and posterior. Anterior had two parts: the prostatic and membranous, the penile and bulbous part, and posterior urethra had the prostatic and membranous part. Okay, so this is how the urethra was divided. And we do sorry, this again I told last time, this is wrongly named. This uh, retrograde urethrogram, which is showing the anatomy. We can see the penile part, the bulbar part, the membranous part, and the prostatic part. Okay, prostate, inside the prostatic urethra there is a protuberance which is called as the verumontanum. Okay, and in this image again, this is a procedure of retrograde urethrogram. We are seeing how we can inject the contrast, and we can see the opacification of the urethra. We are seeing the stricture here. Here we can see the venous, actually it is venous intravasation of the contrast. Okay, venous intravasation of the contrast. Okay, this is nothing but the invertogram and cross table prone lateral weave, CTPL weave. These are the weaves we do to look for the anal atresia as well as anorectal malformation. We divide into high and low anal malformation. This is how the procedure is done, as I explained before. More than 2 centimeter suggests that it is high anal malformation. Okay. Yeah, so this is MRCP, in which we can see the biliary tree clearly as along with the pancreatic duct. And in this image, this is ERCP, in which we can see an endoscopy. Okay, if you see an endoscopy and we see a contrast injection, this is a ERCP. In this image, we can see a stone here, a filling defect which is seen here, which is nothing but a stone. This is again an image of a ERCP. What we have to MRCP. What we have to see here is the pancreatic duct is draining separately, the common bile duct is draining separately. When the pancreatic duct is draining separately, common bile duct is draining separately, it is called as the pancreatic division. Okay, so the difference between ERCP and MRCP is MRI based. Non-ionizing radiation is present here. It's a non-invasive. We don't use anything like endoscopy. We don't use contrast. So it's kind of safer compared to the ERCP, in which we use X-ray, ionizing radiation, invasive, and contrast. So till now we have discussed in the previous class. Okay, so now we will discuss some radiation units. Okay, this is a very important part. These are all not interesting points, but these are all very the lot of questions come from this for your NEET. Okay, so what is the radiation units? Now mainly when we do any imaging in an X-ray, for example in X-ray, so if this is a source or the X-ray tube from which X-ray is produced, and the X-ray goes into the environment and hits the patient, and some of the X-rays will be attenuated and some of them will be allowed to pass through it, and we have a cassette here and we measure the amount of X-ray that is passing through it, and that's how we do the imaging in case of X-ray or most of the imaging modalities. Now what we have to understand is, initially this X-ray tube has produced some amount of X-ray. Okay, it need not be an X-ray tube. It can be anything which can produce a gamma ray, X-ray. Okay, so the different radiations can be produced. So this is nothing but a source. From the source to the environment, we have some amount of radiations. Okay, so in the air, the amount of radiation is present. We can measure that, and that's what is called as the exposure dose. Okay, what we measure, the radiation which is present in the air, is called as the exposure dose. Now this exposure dose will be absorbed by the body, and this is called as the absorbed dose. Okay, understand? So there is some amount of radiation which is present in the environment. When it is passing through the body, some of the will be absorbed, and this is called as the absorbed dose, and this absorbed dose is the one which is causing the damage. Okay, are you guys following me? Just type yes, why, or something. I'm not understanding, like, if you guys are following me. Okay, thank you. Yeah, so whatever is there in environment, we call it as exposure dose, and whatever is there, whatever is absorbed, is called as the absorbed dose. Okay, now one more thing. What do you think, the damage caused by X-rays more, or is it the gamma ray which is causing more damage, which is having more ionizing energy, which is having more damage out of these two? Okay, which of the following is it, X or is it G? Which of the following is? Yes, it is the gamma rays. So am I correct in measuring the absorbed dose by the amount of the radiation which is absorbed? It's not correct for me to tell this much amount of radiation which is absorbed. What I should also consider is what radiation has come, because gamma rays will cause more damage compared to that of an X-rays. Okay, and alpha rays will cause more damage. So actually speaking, X-ray and gamma rays doesn't have much difference, but if you compare an alpha radiations has 20 times that of X-ray or gamma radiations. Okay, out of X-ray and gamma might be more, but it is relatively very less. But when we compare a alpha radiation, it is 20 times more than X-ray and gamma radiations. Okay, so this is why we need to have some measurement which gives us with respect to the radiation. That is what we call it as equivalent dose. Okay, equivalent dose is nothing but absorbed dose into radiation quality factor. Okay, radiation quality factor is a constant for particular radiation. So it just tells us how much damage is caused by it even includes the causative radiation. Okay, causative radiation, is it an alpha, is it an gamma, or is it an X-ray? So that's why the equivalent dose becomes important. Now one more thing which is very important is all these radiations, what does these radiations cause? Now all these radiations can cause some amount of heat dissipation, and it can cause some DNA damage. Now whenever there is any DNA damage, two things the body does. One, it can try to repair. Okay, one, it tries to repair. If possible, it will repair and the cell survives. Okay, cell survives. The second thing is it cannot repair. When it cannot repair, the cell will undergo the death. Okay, cell will die. So both of these things are good for us. Okay, either cell dying or if the cell is getting repaired is good for us. Whenever there is small amount of radiation exposure, it is good. We will not have any residual DNA mutations or any changes in the DNA that is caused by the radiation. Now in some people it will fail to repair and it will fail to die, and that's when we get a genetic mutation. That's when we get cancer. Okay, this is one of the effect. Okay, this is one of the effect of the radiation. Just remember this. Okay, now what does this tell us? Now when there will be DNA damage, not every cell there will be DNA. The DNA mainly get damaged when there is rapid multiplication, when there is rapid mitosis is happening. Now not every cell multiplies. Now we all know that if there is a neuronal damage, if there is a nerve cell damage, okay, if there is a neuronal damage, it will not multiply and form a new neuron. Okay, usually it will not. If a muscle cell is damaged, it will not usually not cause new cell. So what does this tell us? That is neurons more sensitive or less sensitive? Is neuron is more sensitive to radiation damages or the radiation damage, or less sensitive? M or L? Is it more sensitive or less sensitive? Okay, it is. See, neurons are not multiplying. Neurons are not multiplying. Okay, neurons doesn't multiply. There is no mitosis. So white army, Kunj and white army, what do you think? See, it is, yes, most of you are correct. It is less sensitive. Very good. So this is also very important. Now I've been exposed. Okay, I've been exposed to the radiation. Now what happens is my brain is less sensitive than the pelvis. We might think, oh, brain, I have exposed to radiation, more sensitive. No, it is the pelvis will be more sensitive. Why the pelvis is more sensitive to radiation? Why will the pelvis be more sensitive to radiation? Why is the pelvis more sensitive to radiation? Tell me why pelvis is more sensitive to radiation. What are the dividing cells that are present in the pelvis? What are the dividing cells that are present in there are gonads in the pelvis. So yes, they are more sensitive. So this is how. So other than this, other than the gonads, which other cells in the body multiplies rapidly? Which other cells in the body multiplies rapidly? Which other cells do you think they multiply? Okay. Yes, skin. Yes, skin will be the multiplying rapidly. Other than skin, come on. Yes, skin. So there will be erythema. Okay, there will be erythema. Stem cells. Yes, hematopoietic cells. Okay, hematopoietic cells. Yes, hematopoietic cells get damaged. Okay, so there will be the acute hematopoietic syndrome. Yes, mucosa gets damaged. Yes, mucosa gets damaged. So there will be acute GI symptoms. Okay, acute GI syndromes will be present. Okay, what else will multiply? Okay, these are the main things which multiply. Okay, so this is in broadly, I just gave you an idea about everything. So now why I am talking about all this when I'm talking about the radiation units? Because there is something which is called as an effective dose. Okay, there is something called effective dose, which tells us which tissue is getting exposed, and it will tell us how much is the effective dose. It will tell us effective dose of a particular tissue. It will consider the equivalent dose along with the tissue weighing factor. Okay, it will consider it the tissue weighing factor along with the effective dose. So equivalent dose and effective dose are the with the absorbed dose, which radiation is effective, that is equivalent. What equivalent dose tell is 1 alpha radiation exposure is equivalent to 20 X-ray exposure. That's why it is called as the equivalent dose. Okay, so 1 alpha is equal to 20 X-ray exposure. That is okay. Now if this 1 alpha radiation is exposed, it is 20 X-ray exposed. If this is exposing the brain and the pelvis, which is getting more damage, which is having the more effect of it, is given by the effective dose. Just remember the terms. They will just ask, just give you the definition, and just will be the one of the multiple choice. That's all. Very simple it is. You just have to remember these terms. Till now, everyone clear? Everyone clear till now? The next one is the main MCQ in this. Okay, everyone clear till now? Yeah. Okay. Now the SI units of this. We need to know the SI units and the conventional units. Okay. Now the exposure dose is given by the two things. One is the Roentgen and the coulombs per kg. Okay, Roentgen and coulombs per kg. So coulombs, we we know that what coulombs is there for, and if it is per kg, we just use as a SI unit for the exposure dose, and the conventionally we used to use Roentgen. Okay, based with respect to the William Conrad Roentgen, we used to use Roentgen, but the SI unit we consider as the coulombs per kg. Now, very simple, the MCQs will be the exposure dose. SI unit is Roentgen coulombs per kg, sieverts and Gray. Okay, that's very simple. Then very simple. The answer is the coulombs per kg. Okay, the question will be very simple. Only thing is you need to know this. That's all. This one chart you need to know. Okay, the next thing is if you see the absorbed dose, it is given by Rad and Gray. Okay, it's absorbed. AD just suggests that it's absorbed dose. Okay, radiation absorbed dose. It is absorbed dose. AD. Okay, equivalent dose is nothing but ED, EM. That is equivalent dose. Just remember equivalent dose. So A for absorbed, E for equivalent. Again, Gray. A for absorbed, E for equivalent. Just very simple to remember. Okay, then we have again REM. Again here we have E. So it is E for effective, E for sievert. So wherever there is E, we have E, and wherever there is A, we have absorbed, we have A. Okay, very simple. Now all the conventional units are starting with R. Okay, all the conventional units starting with R. Now the blindly if I ask you now, which of the following is a SI unit of anything? Okay, which of the following is SI unit? If I say coulombs per kg, Roentgen, Rem, or Roentgen, Rem, or Rad, which of the following? If my question is Rem, Rad, Roentgen, coulombs per kg. So you just have to see the first letter. Okay, if all the first letters are R, they're all conventional, so other one will be the SI unit. Then if in case they ask particularly, Rad. Okay, whenever the Rad comes, you need to know it is absorbed dose. Whenever there is Gray, you need to know it is an absorbed dose. Next thing what you need to know is whether it is SI unit or conventional unit. So you see the first letter, you know that it's SI unit. You see the first letter, you know that it is a conventional. Okay, very simple it is. Okay, conversions not doesn't matter much. You don't have to know the conversions. Okay, now the next concept is about the PACS. Now what happens in the olden days, there are multiple companies. There is Siemens, there is GE, there is Philips. Okay, these are the different companies which produce different machines. So there is a lot of competition between these companies. So what they did is the Siemens started producing some CT which was good, and GE had some ultrasound machine which was good. Philips had some X-ray machines which were good. But the problem was all the images were read differently. One was in JPEG format, one was in IPG format, one is in the JCOM format. Okay, these are all the fake ones. Okay, I know only about this. Okay, they're all of different formats. Now what happens when I want to display this? One, I can't display everything in the same player that I have. We have like VLC player, MP3 player. I couldn't use the same player to open all of this. So what happens in every institution, they started getting a problem. Now they can't open all these images in the same software that they have. So what they do, what all these companies came together and they came into a just common conclusion that we will all produce all our images in same format. Okay, this is very important out of all things, because this they will ask you. Okay, so what they have come up with is that they all have come up with a common format that is called as a DICOM. Like how our images are saved in the JPEG format, all the radiological images are saved in the DICOM format. We cannot open it in a regular computer software. Okay, regular computer players like MP3 player, VLC. We cannot put our the radiological images or videos in that. So what we need to have is a DICOM player. Okay, a DICOM player, anything which can play DICOM. Okay, Radiant is an example. You don't have to remember this. Radiant is an example. If anyone gives you a CD and tell you to see that in your computer, you cannot open unless you download Radiant, which is for free. Okay, if in case you want to see any images in your computer, you have to download this software. Okay, whatever it is, this one thing you need to remember, DICOM is the format in which images are stored. Now, one thing good happened in the hospitals is that we need to have one player to open this, that is DICOM player. Okay. Now, what this was the initial days, they just came up with this so that it should be easy for the hospitals to run. Now, because they introduced this, now one software they started using everywhere, and now this software can open all the images. Now what happens, there is a CT, there is an MRI, there is an X-ray, there is an ultrasound. Okay, all of this will send the images in the DICOM format, and this all can be opened in one software with us, one player with us. Okay, that is DICOM player. The format in which it comes is called as the DICOM. So then the radiologist used to give the report. Now what used to happen is the clinicians want to see the images themselves. So what, and also sometimes the radiologists are not at the same, at the area where the images are formed. So what the hospital does is all the images are sent into a system called as the PACS. Okay, picture archiving and communication in medicine. Okay, picture archiving and communication in medicine. Okay, so this is the PACS, picture archiving communication system. So this is the uh, uh, a unit which will take all the images and it will store in it, and what it does is it will send it to anywhere we want to access. Okay, we can access from the ward, we can access from the ICU, we can access it in the casualty, we can access in the radiology department. That's why now if you go to any department, any wards, we can see all the images because of this PACS. Okay, picture archiving and communication system in medicine. Okay, PACS. Now, this PACS is helping us to see the DICOM images in all the system. But one thing we need to have in all the system is a DICOM reader. Okay, we need to have a DICOM reader in all this system. So that's what we need to know. The PACS is a format of the image storage in radiology. Sorry, DICOM is the format in which it is stored, and the PACS is the where it is stored and distributed all over the departments. Okay, all the departments. So this is about the PACS. One more thing is the principles in the radiology. Okay, the principles in radiology. So this is the main principles that we follow in radiology. Okay, so one thing is ALARA. What does ALARA stand for? As we saw before, ALARA stand for is as low as reasonably achievable. Okay, as low as reasonably achievable. The MCQ here will be the full form of ALARA. Okay, the full form of ALARA. They'll ask and they'll be as low as reasonably achievable will be the answer. There will be multiple combinations will be given, and the main answer will be the as low as reasonably achievable. And one more thing is they can ask is ALARA in the medicine is seen in relation to which system? Neurology, cardiology, radiology, and biochemistry. So that's where it comes. Just radiology is answer. Very simple, but then we need to know. So what does ALARA stands for? As low as reasonably achievable. Now it just tells that we should not do any radiological procedure unless it is required. We should not randomly send every patient for a chest X-ray. We should evaluate clinically. We should try treating it clinically. We should try giving, for example, not every cough patient with the chest pain is not every cough with the expectoration is a TB patient. We should clinically evaluate, and whoever we think is a suspect of tuberculosis, we can think of getting an X-ray. And not every patient needs an X-ray with chest infection or a severe pneumonia, which we are not able to. A patient who is suspected of a pneumonia, high suspicion towards a pneumonia, then we can do an X-ray. So these are all the principles behind the ALARA. So ALARA just says that whenever it is reasonable to do an investigation, then we are supposed to do. Otherwise, we are not supposed to do this investigation. So that's very simple principle of ALARA. They'll not ask you the principle. Only is you need to know the full form. Okay. achievable is again very important, because I have seen so many times they have changed the achievable terms into something else. Even I have got confused so many times. Just remember this term, as low as reasonably achievable. Now, other than this, there are few things that the three classical points of radiation safety are time, distance, and shielding. What is time? We should expose ourselves minimal, ourselves and patient, as less time as possible. We should not expose ourselves or the patient for longer time. Whenever possible, we should reduce the time of exposure. Then we should always stay as far as possible from the radiation, and we should always use shields whenever we go towards the whenever we are working under radiation. Okay, we should wear lead jackets. Okay, whenever we are doing fluoroscopy or in a cath lab. Okay, when we do a angioplasty procedure and all, whenever we are in the fluoroscopic field, we should always wear a lead jacket. Okay, now distance, again one more question is, when your distance, when you double the distance, okay, when you increase the distance by 2 times, when you increase the distance by 2 times, how much time do you reduce the exposure? Can anyone tell how much time do will you reduce the exposure? When I double the distance, how much time do I reduce the exposure? Just give me the number. What do you think it is? Okay, distance, when I double the distance, what might be the amount? Yes, it is 4 times. It's a inverse square law. Okay, it is inverse square law. The exposure is inversely proportional to the distance square. Okay, it is always the square. So 3 times means it is 9 times you are reducing the dosage. This will be one of the MCQs. So here the mainly they might ask you which are the main principles in the radiation, that is time, distance, and shielding. Very simple. We all know that whenever we are under exposed under X-ray, we should not expose longer time, and we should stay as far as possible, and we should shield. Now one more thing, how do I know that there is radiation? When you're in the hospital, how do you know that there is a radiation? You see this symbol. Okay, you see this symbol, and this symbol suggests that there is something which is secreting radiation. Okay, ionizing radiation. This suggests that there is ionizing radiation. Okay, so whenever we see this symbol, then we should know that I should not stay there for longer time. I should stay as far as possible, and if I am going closer also, I should wear some shield. And this shield is made up of, very simple, they'll ask you, the lead shield is made up, the shield is made up of lead. Okay, they can ask, it's made up of plastic, it's made up of cotton, it's made up of iron, it is made up of lead, it is made up of copper. So these two things we can exclude, but when it's copper, lead, and iron, we might get confused. Don't get confused, it is just lead. Okay, most of the protections in radiology we use lead. Okay, most of the protections. Okay, this is again the principle, the image that will be seen and how we can draw is, that's what is given here. Now main thing, there is in pregnancy, whenever we are exposing patients in pregnancy. Okay, whenever you're exposing a patient in pregnancy, so, oh, sorry, we should not expose a patient in pregnancy. Now, so main thing is, what is this rule of 10? We know that at around 14th day there will be ovulation, and there will be some plus or minus 2 days. Now that's why we have always kept one rule, that whenever we are exposing a pelvis of any patient, unless it is an emergency, we should not expose more than 10 days. We should expose it within 10 days. Okay, so in a non-emergency case, we should not expose, we should do, in a non-emergency patient, if you are doing a pelvis x-ray, it should be done within 10 days. So if there is a question, if I am doing HSG, I am doing it in 8 to 10 days, 10 to 12 days, 12 to 14 days, or 20 to 25 days. Okay, very simple answer. Which is the answer in this? Okay, if I want to do HSG, what will be the timing of HSG that I will do? Okay, I'll give you one more option, 1 to 4 days. Can anyone tell why not 1 to 4 days? Sarah has told 8 to 10 days. Sarah, why not 1 to 4 days? Why don't you do at 1 to 4 days? Or why can I do at 6 to 8 days? What will happen if I do at 1 to 4 days, 1 to 4 days, or 6 to 8 days? Can I do? Or if I am telling I can't do, why? What will happen? Something we saw in intravenous urography. What did we see? Yes, can be a risk of endometriosis, but at when the time of procedure, what can happen? What did we see in intravenous, sorry, not intravenous, retrograde urethropography? Retrograde urethropography. What is the thing that we saw in retrograde urethropography? We saw something. Yes, the contrast can go into the vessels. Okay, there will be the fresh, it will be just endometrium is just shed off. Now if I inject a contrast, it will go into the vessels. Okay, venous intravasation. Okay, venous intravasation can happen. So that's why the preferred time to do a HSG is less than 10 days, and around 8 to 10 days is most of the time we will do. Okay, so if even if you want to send a patient for HSG, what you have to do, you have to ask for the menstrual list, you have to ask, you have to check if the patient is between 8 to 10 days. Now one more rule is there, that is the 8 to 10 days is a short interval. And also what this 28 days rule tells us is that we can do any X-ray investigation unless it's an emergency until 28 days. Yes, it's mainly pelvis. It's mainly pelvis. We are not supposed to do less than 10 days. Even if you're doing rest of the body, even if you're doing rest of the body, we can do up till 28 days. And if beyond the 28 days, we should not do if there is a missed period. If there is beyond 28 days, we are not supposed to do, because we are expecting a menstrual bleed at 28 days onwards. So if in case there was no pregnancy, we are supposed to see a bleed, and then again it will start from 1. We know that 1 to 1 onwards we can do, and but the HSG we cannot do up to 8. We know that, but beyond 28 days we are not supposed to do any X-ray. That's the rule. 28 days rule tells that beyond 28 days I should not do an X-ray. 10-day rule tells that I should do less than 10 days. Okay, 10-day rule is mainly for pelvis. And if in case you are doing an X-ray which is non-pelvis also, we should not do beyond 28 days. Why beyond 28 days? If you are doing, that means you are doing on 29th day or 30th day. That means that there is a missed period. Okay, there is a it need not be a missed period, there is a possibility of a missed period. Okay, so that's why we are not doing beyond 29 or 30th, beyond 28 days. So that's a 28-day rule. If in case you are doing any X-ray also, we should do within 28 days. Don't do beyond 28 days, because there is a possibility of a missed period. Okay, that means there is a possibility of a pregnancy. Okay, so that's why we are not supposed to do beyond 28 days. Okay, one more thing is that if in case it's an emergency, if in case it's a life saving, we should not see the pregnancy, we should do the needful. Okay, that's one more thing. Just remember, there is something called 10-day rule, and there is something called 28-day rule. And that the simple question, we can we use non-ionizing radiation? Give me example of so someone is asking, can we use non-ionizing radiation, sir? Now give me example of non-ionizing radiations. Give me, where do you use non-ionizing radiations in radiology? Ultrasound. Do you do ultrasound in pregnancy? Do you do ultrasound in pregnancy? Okay, someone had a question. Can we use non-ionizing radiation in during pregnancy? So did you get the answer, Pawan? Okay. Okay. So this is called as, sir, within 10 days of the menstrual cycle. Okay, 10 days of the menstrual cycle. The first 10 days of the menstrual cycle. Sorry, I think you didn't get it. Okay, what I meant to say is the 10-day rule is the first 10 day of the menstrual cycle. We are supposed to do any pelvic X-rays. And even if in case you are doing any other X-rays in the body, we should do even the pelvis, including the pelvis, the new rule is the 28 rule, which is, it's little confusing because there are two different rules for the same thing. Okay, X-ray only. So even for the pelvis, these rules, 28 days rule remains the same. Less than 28 days, always you can do, but more than 28 days, it suggests that there is a missed period and you should never do a X-ray. Okay, and you should confirm that is there a pregnancy, and then we have to do the next. Okay, that's all. So whatever this 10 days and 28 days rule is, this is based on the menstrual cycle. Okay, so this is a radiation monitor. So for a radiation safety, okay, these are the things that are required for the radiation safety. One is the alara, then there is time, distance, the shielding. Okay, then what we have to do is, after doing all this is what we have to follow. Any radiologist or any radiology technician, they'll follow alara, time, distance, and shielding. Along with that, they will have to monitor themselves. Okay, they'll have to monitor themselves, because they can't get exposed more than the required, because because of the heavy workload in radiology, they will not be aware how much time they're spending there, how much distance they're maintaining, and the shielding also not every time we can follow strictly. So always we maintain a badge, or TLD badge, what you call it. Okay, thermoluminescence dosimeter. Okay, thermo for heat, luminescence means it produces the light, and dosimeter, it gives the dosage of the exposure. So what it tells us, it tells us how much is the exposure that we have has happened. Now, very simple, to monitor the radiation exposure, what do we use in the radiology department? TLD badge, thermoluminescence dosimeter. Very simple MCQ. Okay, so they'll just ask you. Now, the second question will become one level higher. Thermoluminescence dosimeter is based on the principle of, or it contains, what chemicals does it contain? Okay, it contains lithium fluoride or calcium sulfate dysprosium. The most commonly they use lithium fluoride. Now, how this TLD batch works? So this is how a lithium fluoride or calcium sulfate dysprosium will be present, in which all the electrons will be present at a low energy state, and this is how a fresh TLD batch is coming from it's all controlled under Baba Atomic Research Center. Okay, Baba Atomic Research Center is controlling all this. They have their subunits in multiple places like Chennai, Bombay, and all, and they will send us the TLD batch every 3 months. We need to change our TLD batch. So every TLD batch is taken, used for 3 months continuously whenever you are working in the radiology department, and then sent back to the centers, and they will replace with a new TLD batch, and again use for 3 months, again send it, and every 3 months you'll be measuring how much is the exposure. Now, what happens when I'm getting exposed? Now, I'm in the radiology department, I'm wearing a TLD badge, I go into the radiation exposure area. The radiation will be given to the electrons, mainly the X-rays, and this will be absorbed by the electrons, and this energy will give the energy to the electrons, and it will go from low energy to high energy, and it will be staying there. Okay, the electrons will be going from low energy to a high energy, and it will stay there. Now, once I send this back to the center, what they do is they will heat it. Okay, they'll heat this the lithium fluoride, which is exposed to electron, which has high energy electrons. Now what will happen? Now this heat will make the high energy electrons to go back to the low energy, and whenever this does this, it will emit the light. It will emit light. Now, whenever this emits light, so it will emit light based on how many electrons have gone to higher energy state. So, and what decides the number of electrons going to high energy state? It is the number of radiation which is coming from here. So by seeing the amount of light, we can measure the amount of radiation exposure, and this is why it is called as thermo, that is we are heating it, luminescence because it is giving light, dosimeter because it gives the dose. Okay, so this is why it is called as the thermoluminescence dosimeter. Now in this, what we need to know, what is the chemical used? Lithium fluoride, calcium sulfate dysprosium. What is the principle? Thermoluminescence. And how often should we change the TLD batch? Every 3 months. And it is controlled under the Baba Atomic Research Center, and all the lights will be measured in something called as photomultiplier tube. You don't have to remember. Just remember all till this much enough. Okay, photomultiplier tube will multiply the amount of the light, and it will measure there. Okay, it is just amplifying and measuring it. That's all. It's like our ECG machine. Yeah. So where do you wear this? We usually wear this inside the lead jacket. Okay, we should wear it in the shirt or in the collar, and then we wear lead jacket on that. Okay, wearing outside the lead jacket is bad. Okay, so this is about the radiation safety, radiation units, and now we are going to the radiation effects. Now, as I told you, what will happen whenever we expose to radiation? Come on, let's recall what all I have told. Whenever there is radiation exposure, okay, whenever there is a radiation exposure, what will happen? What will happen to the body? One is the cell death. Then there will be what all tissues will be getting damaged? What all tissues did we tell will be getting damaged? There is skin, which will cause erythema. Good. GI system will get, yes, there will be mutated. There will be some mutations. Yes, there will be mucosal damage. That is GI damage will be there. GI mucosa will be damaged. Yes. So these are the damages that we are seeing. Mucosa, acute GI symptoms. Good. Okay, so these are the things which will happen. Now, one thing we have to know, as I give more and more and more radiation, okay, as I give more and more and more radiation, will the mucosal damage, the severity will be increasing in the mucosal damage or not? I give more and more radiation. Will the severity of the mucosal damage will increase or not? Yes, there will be increasing. Okay, but will the severity of the mutation can increase? Can the severity of the mutation can increase? Severity, I'm not telling the probability. Okay, the probability is different. The severity, mutation is like all or none phenomenon. It happens or not happens. Okay, and it can happen. I have got one rad of exposure, you have got one rad of exposure. For you it might mutate, for me it may not mutate. It is just all or none phenomenon. Its probability might increase. If I get 10 rad, chances of me getting might increase, but it is all or none phenomenon. Okay, so it is an all or none phenomenon. So whenever we have some things like, so cancer, is it like severity increase or is it all or none phenomenon? Cancer, is it like all or none, or is it like severe? It will become more severe cancer, less severe cancer. It is again all or none, but won't multiple mutations in a cell add up, sir? Yes, multiple mutation, what the body does. Every mutation, what the body does, body try to kill it, body try to repair it. If in case it fails, it will lead to cancer. But the severity of the cancer doesn't change. Okay, one cancer will have one mutation. Okay, one cancer can have one mutation because of the radiation, but it is just a cancer. One cell might get mutated, it will lead into cancer, or it can lead to a genetic mutation, hereditary, some problem in the kids, or this all things can happen because of the genetic mutation. But it will not be causing a severe cancer, less severe cancer. Cancer or not, all or none. Okay, so that's how it is. So if there is a cancer, if there is a genetic mutation, if there is a hereditary effect, this all or none phenomenon. There is not like, as I increase the radiation, the severity increases. Only thing is it is all or none. It can happen at any dose. Okay, so there are two terms. One is stochastic effect, and the other one is a deterministic effect. Okay, so the questions will be very simple. All of the following are the stochastic effect. All of the following are the deterministic effect. Now, in the stochastic effect, what will happen is, it is dose independent. Okay, as I increase the dose, it is having linear relationship. There is no threshold. There is nothing like I have to give 10 gyre, then only it will start causing the effect. Okay, there is one more thing, that is the deterministic effect. That means that after giving 10 gyre or after giving 2 gyre, after giving 6 gyre, sorry, after giving 6 gyre, I will develop some symptoms. So that means that it is deterministic effect. Okay, it is very specific. I give you 2 gyre, this will happen. I give you 10 gyre, this will happen. I give you 20 gyre, this will happen. So what does that tell? The dose will decide the severity. Okay, understood. That is the deterministic effect, and it is having a threshold. So whenever I say there is a threshold, what does that tell you? This is the severity depends on the dose. Okay, so more the dose, more severe it will become. So all these deterministic effects. So can we give me some examples of deterministic effect? Okay, after giving certain dose, this will happen. After giving certain dose, this will happen. So what are these deterministic effect that can happen? Can cancer happen as a determination? I give more dose. Okay, more severe the cancer. No, it is all or none. Probability is more with more dosage. That's all. Okay, probability is more with more dosage. So that's a very simple stochastic effect. The probability increases with the dose. The severity increases with the dose, which is correct. The severity will not increase with the dose. Okay, in the stochastic effect, if I give you example of stochastic effect, is nothing but the genetic change, the cancer, and the hereditary effects. These are the example of the stochastic. So it doesn't, the severity doesn't depends on the dose. The probability might depend on the dose. So that's all. That's a very simple. These are the stochastic effect. Now what are the deterministic effect? Now wherever there is more and more cell death, more and more cell death, what are these more places where there is more and more cell death? Now if I say I give 1 to 2 gyri, if I give 1 to 2 gyri of the dosage, then the patient will develop acute hematopoietic syndrome. Okay, what is acute hematopoietic syndrome? All the hematopoietic cells will reduce. Okay, acute hematopoietic syndrome. If I give the dosage of 6 to 10 gyri, then there will be acute GI syndrome. What is acute GI syndrome? There will be nausea, there will be vomiting, there will be diarrhea, all because of the mucosal damage. If I give more than 20 gyri, then there will be acute CNS syndrome. Okay, acute CNS. See how much dosage does CNS require and how much dosage does a hematopoietic syndrome require. So this is how we know that which needs more, which is less sensitive and which is more sensitive. So if I ask you next question, which of the following is least sensitive to radiation? Okay, which of the one is most sensitive to radiation? Correct. CNS is the least sensitive. Which is the most sensitive to radiation out of these three? Okay, so this is how you answer. Okay, very simple it is. Okay, these are the questions you will count. Okay, very simple. You just have to remember that values. Okay, so this is the deterministic effect and the stochastic effect. The same thing. These are the examples. Other examples are skin erythema, the cataracts. Then these three things are together called as the acute radiation syndrome. They happen immediately. Cataract will take time, long-term exposure. Skin erythema also will have piling up of the exposure, or one day long exposure also can happen. But acute syndromes of radiation includes acute hematopoietic, acute GI, and acute CNS syndrome. Okay, so this is the dosage, okay, which I already told you. Just remember 1 to 2 gyri, acute hematopoietic syndrome, 6 to 10 gyri, acute GI syndrome, and more than 20 gyri, acute CNS syndromes. Okay. Okay. Now there is some guidelines given by the AERB. This is the one more question. Okay. Very simple. This is, don't learn multiple things. You might have the charts with multiple values when you're studying in any NEET books. All will give multiple values. Just remember few of them. Okay, you just remember whole body, the lens, and skin, other organs. So just remember others. Okay, this you just remember others. Don't remember particular things. whole body, lens, and others. Okay, whole body, what is the exposure that is allowed? Then in pregnancy we'll discuss separately. Okay, 20 millisieverts per year for 5 years. Okay, 20 year for 5 years means how much? 20 into 5. Okay, almost 100 can happen in 5 years. Okay, so in 5 years 20 millisieverts per 5 year, but 1 year can have 25 millisieverts, 27 millisieverts and all. Okay, so that is not a problem. In total of 5 years accumulation, first year I got 25, second year I got 15, third year I got 20, fourth year I got 20. Now net is how much per year? It became 20 millisieverts per year. So it is, even if 1 year it has gone beyond 25, no problem. Okay, so that is fine. So 20 millisieverts per year for 5 years. But if 1 year exceeds 30, it's again the beyond the limit. Okay, 1 year it should not exceed 30. So 1 year, if it goes 31 millisievert, then done. You don't count for next 5 years. Okay, they'll be having some rules that they have to stop from working for so many terms and all that. Okay, so if it is 20 per year for 5 years, no problem. Or if it is 30 per year is also no problem. But if it is more than 30 per year or more than 20 per year for 5 years, then it is beyond the limit. Okay, that's the difference between these two. Okay, that's why I just explained you so that you don't get confused. Two things are there, but what the two things just means is that 20 millisieverts per year for 5 years is allowed. So cumulative 20 millisieverts per year is allowed, but 1 year if you see more than 30, then it is again not allowed. Okay, so in the general public of the same thing for per year is 1 millisievert. Okay, usually the general rule is 1/10. Only here it doesn't follow. Okay, 1 millisievert per year is for the general public. This is for a occupational exposure, a radiologist, orthopedician, or a cardiologist, or a radiology technician, cardiology technicians, all these who are working under the radiation. If the limitation is this, but if a patient is coming per year, his limitation is 1 millisieverts per year. Okay, very simple it is. Now this is the only confusing. Next, for the lens, it is 150 millisievert. 1/10 of it is for the general public, that is 15 millisieverts. Then for rest of the body, 500 millisievert is the allowed dose. For general public, 50 millisievert is the allowed dosage. Okay, now in the pregnancy, in the working group, hospital working person, less than 2 millisievert per year is allowed. Okay, only less than 2 millisievert per year is allowed. Remember, only this much. Okay, very simple. Whole body, if you consider 20 millisieverts per year for 5 years is allowed, and in general public it is 1. Only here you remember general public and this you can understand that later. That is 20 cumulative is fine. Per year 30 is not allowed. Okay, other than that 150 per for lens is allowed. For general public, 1/10 of it. 500 for organs are allowed. 1/10 of it, that is 50, is for the general public. Okay, this is very important. Okay, they'll ask you this. See, I am covering you radiation, the radiation safety, the radiology, nuclear medicine. That's why all these are very important. Questions can come from nuclear medicine as well, and nowadays the questions from nuclear medicines are more. Okay, it's becoming very useful. Now, how can I calculate? Now, if in case you just want to blindly calculate little bit how much is each dosage, okay, you can just get a rough idea based on each exposure. So each X-ray is equal to 0.02 millisievert is the exposure. Okay, one X-ray, just one X-ray if I expose today, one chest X-ray if I take PAV, 0.02 millisievert. This is not only for you to measure, this is an MCQ. Okay, this is an MCQ. They will ask you what is the effective dose of a 1 PA chest X-ray, 0.02 millisievert. I'll give you few values. This much is the only thing that you need to remember. Beyond this, you can just assume like, the X-ray chest is this much, pelvis is this much, maybe abdomen is this much. You can assume like that. Okay. So the second thing that we need to know is head. Okay, AP and lateral skull is 0.06. Now, why this becomes more exposure is whenever there becomes more and more bone, and you have to get more and more contrast, then again you will have to increase the dosage. That's why all this happens. And again, it depends on two things. One, how much is the bone there, and second thing, how much is the surface area. Okay, how much is the surface area? Two things. Now the next thing is the abdomen and pelvis. Okay, abdomen and pelvis, it will be 0.7. Even if the abdomen or the pelvis are, it is 0.7. And if you take LS spine, it is 1 millisievert. So remember that all the X-ray modalities are having almost within 1 millisievert. Okay, simple X-ray modalities are having within 1 millisievert. It is in the order chest X-ray, then the skull, then the abdomen and pelvis, then the LS spine. Okay. So next thing is the effective dose in the other things includes the, the CT skull is having 2 millisieverts and IVU is having 2.5. IVU is also an X-ray, but what do I do in IVU? I take an X-ray before giving injection. Then I take it 1 minute for nephrographic phase. If you remember what I've told, nephrographic phase. Then I take it sometimes at 5 minutes, sometimes at 10 and 15, and one more at 30 delayed. Okay, so they will take multiple and different combination we use based on what exactly we want to see. Okay, so that's why the exposure is very high. It's almost higher than the CT. Okay, so 2.5 millisievert, and the barium study is having 3 millisievert. Again, barium will have multiple images, AP, oblique, then stomach we have to see the esophagus, gastroesophageal junction, separate images we have to take. So again, the dosage here is higher. So 3 millisievert is for the barium study, and the bone scan will have the dosage of 4 millisievert, and the barium enema is having 7 millisievert. Again, why? Because we have to see the rectum, we have to see the sigmoid colon, ascending colon, the hepatic flexure, splenic flexure, transverse colon, the descending colon. Individually, we'll have to take different exposures. So it will have a large amount of exposure, 7 millisieverts. See how the severe. So whenever we ask for an investigation, this is why we have to be very careful, because we are exceeding beyond the limit. Okay, beyond the limit of the exposure. Okay, so this is the effective dose for the CT abdomen is 10 millisieverts. Then for a SPECT scan, it will be 2 to 5. And then for a PET scan, okay, so this is a SPECT. Okay, this I'll discuss you when I'm discussing about the nuclear medicine in cardiology. Okay, so this is the heart. Okay, we do a scan in the SPECT scan to see, is this tissue viable? Okay, is this tissue viable? Okay, that's why we are doing this scan. Okay, then this is the PET scan. PET scan will have 5 to 15 millisieverts. Okay, almost the maximum is in the 5 to 15 millisieverts. Sometimes we do this thallium scan. The SPECT can be done using various things. There is something called thallium scan. They say it can go up to 20 millisieverts. Not important. Just remember this much. Okay, these values are very important. I have told you at the first class itself, so that you can revise this. Now only write all the values and all the terms that I have told you. So these are very few in radiology that we have a lot like to remember like this. Only in the physics part is little remembering thing. This you have to write it in the notes and keep revising till you're neat, so that it will be useful for you. Okay, so again the same thing which I already told you. Okay, some messages. Sir, how could you calculate in intraoperative exposure when using X-ray during a procedure? So the some question is, how do you use an intraoperative whenever using intraoperative X-ray? So again, ideally, whenever you are using in the intraoperative, there will be one technician. He will be exposed more, so he need to measure it. If an orthopedician is doing everyday X-ray exposure, ideally even he is supposed to wear a TLD badge. Okay, whoever is exposed under X-ray room is supposed to measure this. So TLD, if you ask me, is TLD, this is not for an MCQ, it's just for a general knowledge, is TLD badge only one thing which can measure? No, there are some things. This is called as pocket dosimeter. Okay, pocket dosimeter. There is something called as Grigor-Muller chamber. Okay, Grigor-Muller chamber. So this Grigor-Muller chamber immediately tells how much is the exposure has happened at right now. Okay, so there are something which will tell you how much you have been exposed in last 1 hour. So there are a lot of things. Pocket dosimeter, ring dosimeter, you can put it like a ring. wrist band dosimeter. We can put it in the wrist. So there are multiple things which you can access if you are on regular exposure or on any exposure. If you are getting exposed under X-ray machines, then you can buy any of this and you can check yourself as well. Okay, so there are multiple things, but TLD badge is very important because it's used by everyone. Okay, so that's about the introduction to radiology. Next thing, I think it's time, I guess. So next class I'll be taking about X-ray physics. See, first few classes are little boring, but I think you should attend all of this, because next is X-ray physics, in which I'll tell you how a X-ray works. Okay, how a X-ray machine was built, how it will be built, because I'm not telling because you need to know, because X-ray machine physics, a lot of questions are asked in AIMS, a lot of questions asked in PGI, a lot of questions asked in NEET. So that is important. So I'll teach you how it is built, and I will teach you how an X-ray works. It's very important to understand every X-ray. You would have learned chest X-ray. I think by now, by a lot of, I think 2-3 classes of radiology, chest X-ray has happened. So you already know a lot of chest X-ray. So it will be easy for me to tell the physics behind it now and make you understand better. So it's always in radiology, it's not of diagnosis. Okay, it's a lot about the physics, and every time you see an image, you have to interpret it. You should not like you should not say, is this white patch consolidation, or is this white patch collapse? Okay, it's same as like your clinical examination. You should evaluate every imaging. Okay, so it's not like, and one more thing, don't think radiology is like all or none phenomenon. It is not a stochastic effect, it's more like a deterministic. You see more and more, you evaluate more and more, you get more and more idea about it. Okay, and sometimes there are wrong reports that's given by radiologists. It's not easy task. Okay, radiology is a difficult task, like how uh, clinician misses physical examination findings. It's not easy to interpret the physical examination. It's difficult, we know, after studying for so many years it's difficult. Same way radiology also is very difficult to uh, say that this is this diagnosis, but we can get some clues. That's what we are trying to teach you, and that's what we are learning in radiology. Okay, so try attending all my physics classes as well, and eventually it gets very interesting when it comes into chest X-ray, when it comes into CTMR. But the thing is, if you are not knowing the physics behind it, it will be very difficult for you guys to understand. Okay, that's why I'm taking physics classes first, and then eventually we'll build up with the entire radiology. Okay, so before your exam, I'll try finishing everything. Okay, yeah, so that's it for today. Thank you everyone. I hope you all have taken notes of this, because see, watching video again and again is of not of much use. Always in my classes, try, or any classes that you're attending, try taking your own notes. Don't try taking screenshots or anything. Try taking your own notes. Don't try reading PPTs, because it's prepared by me. I will know better about it, but you will not know better about it. Okay, try writing your notes. Write it with lot of spaces, so that next time when you see some extra point you can add, or if you see some changes in the recent advances, if you're seeing some changes, you can add there. And keep a thicker notebook for each subject, so that in one notebook you'll have everything and you can revise it for the need. Okay, and people who are studying from second year, third year, or first year, this is the right time to start. There is nothing like you have to start after internship, during final year. This is the right time, whichever year you are in. Okay, so you all can do really well in the NEET if you start early. So I request everyone to start early, start studying for NEET. Don't have to use all your time on this. Whatever time you're using on studying, use this. Enjoy life as well. Okay, thank you everyone. Any doubts you can ask me till our next class.
Thank you, sir, for this session, sir. It was truly means the physics was truly interesting, because mainly when we study radiology in means undergraduate, we generally see about only the science, but no means the science and the various disease pathologies, but not regarding the actual physics and the actual mechanism behind it. So it's really means good. It was truly informative, and the part about the radiation safety, it is not generally discussed well amongst the undergraduates. So it was good to learn that was that as well.
Yeah, thank you so much. And you guys, it's useful for you guys also, and it's very important for NEET. Whatever I am teaching is mainly for NEET nowadays. Okay, so I'm mainly concentrating on NEET. Whoever is interested in that, and it will be helpful for your practical purpose as well, day-to-day activities. Okay. Yeah. Any doubts?